Good morning, everyone. Today we are going to have class on Papulosqamous disorders. This is a huge group of classification. Among this, what we are going to discuss today is Lichen planus and psoriasis. These are the content which we are going to be discussing under the heading Lichen planus. Now, what is Lichen planus? Lichen planus is a chronic inflammatory disease of unknown etiology, which is affecting skin, mucous membrane, hair, and nail. This is usually characterized by 6 P's, which is pruritic, purple, polygonal, flat-topped, papules, and plaques. The incidence is around 0.2 to 1%, and there is no racial discrimination. The most common age group which affects are 30 to 60 years of age group, but it can affect all the age group and both the sexes together. Now, how does this lichen planus develops? What might be the reason? There are many triggering factors which are associated, which we'll be discussing later. Now, what might be the etiology? Many suggest that it might be an autoimmune damage of the basal keratinocytes, as many of these patients have associated autoimmune disorders like ulcerative colitis, myasthenia gravis, lupus erythematosus, alopecia areata, and diabetes. And the exact nature of the antigen which stimulate this process of autoimmune disorder is unknown, and many of these lichen planus patients have HLA types which might be frequently involved are B27, B51, BW57, DR1, DR4, and DR6. These antigens can be of two types: one, self peptide, or exogenous agents. Coming to the exogenous agents like drugs, these are the commonly used drugs which can trigger lichen planus type of lesions. Coming to the other exogenous agents like virus, hepatitis C, human herpes 6 virus, vaccinations like HPV, killed influenza, MMR, DPT, H. pylori infection, and contact allergens like amalgam, which are used for dental filling. Now, coming to the pathogenesis, how does this peptide, which is a self peptide or an exogenous agent, trigger formation and leads to basal keratinocyte death? Now, any antigen which enters our skin will have to bypass the antigen presenting cell, which is Langerhans cell, which is present in the stratum spinosum, which is present in epidermis. When this antigen enters the epidermis, this is engulfed by the antigen presenting cell present in the epidermis, which is Langerhans cells. Then they pass through the lymph channels and go to the lymph nodes and start present themselves to the T lymphocytes. When this is present to the T lymphocytes, a series of actions along with ICAM, interferon gamma, and other things leads to activation of CD8 lymphocytes. These CD8 lymphocytes are killer cells. So these start to develop either intrinsic apoptotic pathway or an extrinsic apoptotic pathway, leads to damage of the basal keratinocytes. And along with these apoptotic pathway, there is also release of matrix medullary proteinases. There are multiple, among them 9, 13, and other things, lead to damage of the basal keratinocytes and formation of colloid bodies. These colloid bodies are nothing but dyskeratotic keratinocytes which are damaged by this process. And these colloidal bodies are one of the diagnostic factors which help in our histopathology to diagnose lichen planus. Now coming to the clinical features, as we know, already discussed the 6 P's. When we see on a patient of these 6 P's type of pleuritic, purple, plain topped, papules, plaque, and all those things, we suspect lichen planus. Along with that, what we can see is also a Wickham striae. Wickham striae is, you can see a lazy pattern of white lesions around here, which is one of the diagnostic factors. It is most commonly also most perfectly seen in the oral lesions. These common sites are forehand, legs, neck, and sacral areas. And what you can see is also Kobna's phenomenon. Kobnazation is something where any clinical lesion start developing on the injured area. Along the injured area is called as Kobna's phenomenon. You can see a straight linear lichen planus clinical types of purple plain topped plaques which is seen here on the injured area, maybe because scratching or some random injury. Now coming to the clinical types, there are many clinical types. Among them, acute lichen planus, annular, atrophic, hypertrophic, inverse, bullous, pemphigoides, pigmentosus, lichen planopinaris, and linear LP. Coming to the distribution types, there is something called as nail lichen planus, which affects 10% of the cases. What nail findings you are going to find are lateral thinning, longitudinal ridging, and fissuring. Along with that, you can see a pterygium formation. Pterygium formation occurs because fixation of the proximal nail fold to the nail bed, they will not be able to grow, so you will have a inverted cone shape appearance of pterygium formation. Oral lichen planus, prevalence of 0.2 to 2%. Oral lesions occurs in 70 to 70% of the cutaneous LP lesions. The types of lesions which comes in oral lichen planus are reticular, erosive, atrophic, bullous, papular, plaques, pigmented. You can see a white streak of lacy pattern in the buccal mucosa along with the erosive type of LP and white plaques over the tongue. Coming to the histopathology, which is one of the diagnostic factor to diagnose lichen planus: compact hyperkeratosis, focal wedge-shaped hypergranulosis, acanthosis, sawtooth retinitis, liquefaction, degeneration of the basal cell layer, band-like lymphocytic infiltrate present in the papillary dermis, and colloid bodies, or it's also called as civetty bodies, which are dyskeratotic keratinocytes present in the lower epidermis and the upper dermis. These are the differential diagnosis features which you have to keep in mind when you are diagnosing a case of lichen planus. Prognosis, this is very much self-limiting, but the most factor which you have to counsel the patient is the factor of recurrence. These lesions can come back any moment of the time later in their life when after resolving, but usually this take around 3 to 6 months to resolve, and they resolve with hyperpigmentation, and this hyperpigmentation initially it will take time to form a normal skin, maybe around 2 years, because of when these melanocytes which are entering the dermis, which are deeper components, it is very difficult to treat with any of the depigmenting drugs. These melanocytes which are present in the dermis will be engulfed by the macrophages there and slowly pass out to the lymph channels out. Treatment, the most common treatment we do are topical potent corticosteroids. Calcineurin inhibitors can also be used in hypertrophic type of LP or oral LP, where intralesional corticosteroids or injection can be given to the affected hypertrophic lesion site, so that there will be faster resolution and symptoms free. Phototherapy also can be used. Among systemic therapy, antihistamine is very important because this is a very pleuritic condition, and if you don't subside that pleuritic, you can develop Koebner phenomenon and induce many active lesions also. If topical corticosteroids, phototherapy, or all the antihistamines are not able to relieve, we'll have to go with the second step, that is with systemic drugs. Among them, you can start with corticosteroids, acitretin, griseofulvin, cyclosporin, mycophenolate mofetil, and thalidomide cytotoxins, which has better response. Coming to psoriasis, these are the headings which we'll be discussing psoriasis under. Now, what is psoriasis? Psoriasis is a complex, chronic, multifactorial inflammatory disease that involves hyperproliferation of the keratinocytes in the epidermis with an increase in epidermal cell turnover rate. There are various factors which affects the factor play. These are immune factors, environmental factors, hereditary, and among hereditary source 1 gene, HLA, CW6, HLA factor, which can, any person which is affected with this, they can develop psoriasis and psoriatic arthritis also. This affects 2 to 3% of the world population with male to female equal ratio. There are two types. Type 1, which is early onset, more severe, long-standing disease and positive family history. Late onset, milder form, family history is usually absent. Coming to the triggering factors: trauma, mechanical, chemical, or radiation, any type of trauma; infections like streptococcus, staphylococcus, and HIV; stress, alcohol and smoking; metabolic factors, hypocalcemia; sunlight, usually beneficial but in some cause exacerbation. Other triggering factors like drug, among them beta blockers, lithium, NSAIDs, ACE inhibitors, antibiotics, terbinafine. These are the drugs which we as a dermatologist we'll be using most commonly, so we have to be careful. Coming to the history, usually patient comes with history of itchy, erythema, which is red area, and increased skin scaling and peeling. There will be new lesion appearing at the site of injury and trauma, that is usually occurring as Koblenz phenomenon. And these patients, most of the time, they'll start coming in the winter, because winter exacerbation is very commonly known. Improvement with summer is seen, but a severe exposure of sunlight, which will induce stress on the body, can also exaggerate psoriasis. The lesions will be erythematous, scaly, papules or plaques, which is lesions is characterized by well demarcated erythematous plaques with adherent silvery white scales. The main cardinal features which we have to look at are erythema, induration and scaling. The most common type is psoriasis vulgaris. Mostly the extensor sites are involved: elbow, knee, scalp, lumbosacral areas, intergluteal clefts, palm soles are involved commonly. On scraping a lesion of psoriasis, on the blend glass side, silvery scales are observed, followed by a glistening transparent membrane. This is called as Berkeley's membrane. On removal of this Berkeley's membrane, you see a multiple small bleeding points. This is called as Auspitz sign. To demonstrate this Auspitz sign, you do a test called as Garretash test. Now, on the psoriatic lesions, you see a blanched halo ring around the surface. This blanched halo along the psoriatic lesions, this is called as Wurnoff's ring. It is said that they have inability to produce PGE2 around this lesion, so there will be vasoconstriction and halo lesion, and this is Auspitz sign, pinpoint bleeding on scraping, and this is called as Berkeley's membrane. Coming to the morphological types, these are classified as chronic plaque psoriasis, gutted psoriasis. Gutted psoriasis is most common in children and usually affected by infections like streptococcal. Pustular psoriasis, erythrodermic psoriasis, follicular psoriasis, linear psoriasis, annular psoriasis, and Rupert type of distributional morphological psoriasis. This is chronic plaque psoriasis. You can see a huge area of basically affecting the extensor surface of the leg. Gutted type of psoriasis. This is multiple psoriatic type of plaques, papules present all over the body. This is erythrodermic psoriasis. Erythrodermic psoriasis basically means there is more than 90% of body surface area involvement. This is pustular psoriasis, where you can see multiple small pustules also and many coalescing to form a huge pustule. Now coming to distributional type of variation and types of psoriasis, these are scalp psoriasis, palmoplantar psoriasis, nail psoriasis. Among the nail psoriasis, the features which you can see are pitting, onycholysis, where there is separation of the nail plate from the nail bed, subungual hyperkeratosis, which means there is thickening of the nail bed, splinter hemorrhages. These are small hemorrhagic capillaries which are present below the nail plate, which can get visible during such type of nail psoriasis features. Mucosal psoriasis, inverse psoriasis. Inverse psoriasis means there will be sparing of the extensor surfaces and involvement of the intertriginous areas. This is a scalp psoriasis. You can see there is extension even below the hair. This should be differentiated from seborrheic dermatitis, where there will be greasy scales which are very attached and they don't cross the scalp margin in seborrheic dermatitis. Palmoplantar type of psoriasis. Nail psoriatic features, you can see ridging and little bit of nail pitting in this picture. In inverse psoriasis, where intertriginous areas are mainly involved. Now coming to psoriasis in children, these are more common in girls and these are more pruritic. Lesions are relatively thinner, softer and less scaly, more frequently precipitated by infection. Facial involvement are more common than in adults. Psoriasis in HIV, this is important as a feature because HIV and psoriasis, the prognosis is bad, recalcitrant to treatment, and the patient will have very severe involvement. As this recalcitrant, we can't start using any higher ends of immunosuppressants because the patient is already immunosuppressed. Psoriatic arthritis, this is also important because as in most of the patients will be unaware, when they start WB complication, they might go into the features of arthritis mutilans, where there will be complete destruction of the joints, or they may start developing getting deformities where distal interphalangeal joint involvement might be seen. Coming to the diagnosis, it can be diagnosed with the histopathology where skin biopsy is done on the lesional area. What you are going to see from above down is the first layer of the epidermis. You are going to see parakeetosis. What is parakeetosis? Parakeetosis means there is nuclear remnant which is usually absent in stratum corneum. Among that, what you are going to see is micro-Monro abscess of Monro where neutrophil accumulation. This is basically a sterile abscess. And the second layer, granulosum, will be absent in psoriatic lesions, and there will be acanthosis, suprapapillary thinning, and spongiform pustule of Kogoj in the stratum spinosum. There will be regular elongation of the rete which will give an appearance of camel foot appearance. And next, below the epidermis, you can see a dilated tortuous capillaries on a dermal papilla. These dilated tortuous capillaries of dermal papilla, suprapapillary thinning, acanthosis, absence of granular layer are all the reasons why when you scrape more and more in a Garatas test, you start getting pinpoint bleedings. These are the comorbidities will be associated with psoriasis, and when it is associated, the condition will be severe and recalcitrant to the treatment. The differential diagnosis which we have to keep in mind when we are diagnosing a case of psoriasis, like I said, seborrheic dermatitis, it should be kept in mind when we are diagnosing a scalp psoriasis. Management of psoriasis is basically very important because this is a long-standing disease, very recurrent disease, and very recalcitrant also. So this will affect the quality of the life. The patient might get depressed, and so there might be other complications. So we have to take care of them, counsel them regarding recurrence, the time which take for the treatment part. If it is not working, we have to step into the other modalities very soon. The general measures what we have to counsel them are about recurrence, then avoiding of trauma and other irritating and triggering agents, weight reduction basically to prevent metabolic syndrome, intake of alcohol and beverages, and smoking should be asked them to avoid as it plays two times. One, these can exaggerate the psoriatic lesions as well as it plays a role in treatment. Any of the drugs which we give like methotrexate can also affect the liver. Along with that, these alcoholic beverages and other things might damage liver too. So both simultaneously together, the patient may start developing other features to liver damage. Among them, the basic therapy we start first is topical therapy. The previously used things are like tar, anthralin, and salicylic acid. Basically, these are all anti-proliferative and prevents excessive keratinization, and they maintain the keratinization level to become at the normal rate. The most commonly topical agents which we use right now is topical corticosteroids and topical vitamin D analogs. Topical retinoids can also be used right now, but it's very costlier, so not much patients are affordable. Phototherapy is also one of the very good indication. Among them, narrowband UVB, which is NBUB, which we call. This is most commonly used, and this will lead to rapid clearance of the lesion. But phototherapy alone is not such a very effective treatment, so it is usually combined with other mode of treatments like methotrexate, retinoids, so that the patient will have rapid clearance and less dosing of these systemic drugs can be used, so the side effects can also be reduced. Pua Photochemotherapy. In this, what we do basically, we give oral Suralin and we ask them to go for sunlight or give a UVA type of phototherapy, so that this basically will go and affect the nuclear adducts at the nuclear level and stop the production of cytokines and other modifications which will help in hyperproliferation of the skin. But this phototherapy, Pua type of phototherapy, should be very carefully used. We should always ask for the photosensitivity history in the patient or see conditions where lupus erythematosus, porphyria, xeroderma pigmentosum type of patient should always be contraindicated. And this Pua can also be used in combination with topical calcipotriol, oral retinoids can also be done. Systemic therapy, usually we start only when there is more than 10% of body surface area involvement, or when it is basically having a negative effect on the quality of life of the patient, which is obstructing their regular day-to-day basis activities or not be able to go to work because of the same factor. Among them, the drugs we use are methotrexate, cyclosporin, acitretin. Uh, Among these two, methotrexate and cyclosporin will have a shorter duration of action. So basically, they'll have faster action. Maybe 3 to 4 weeks, the patient will start responding. But acitretin will take some time. But the advantage of acitretin is that this can be given for longer duration of years, maybe up to 1 year. So the patient might be in remission for longer duration. And also, along with that, as it doesn't have any immunosuppression action, this can be used in HIV patients also. Other systemic drugs which can be used are azathioprine, fumaric acid esters, hydroxyurea, leflunomide, mycophenolate mofetil. Steroids should always be avoided in a patients of psoriasis because this will cause exacerbation of the lesion on tapering of steroids. But there are some few conditions where systemic steroids should be given where to weigh the out-risk ratio. Among them, a patient with hyperacute polyarthritis or a severe generalized pustular psoriasis or an erythrodermic psoriasis, which requires to decrease the complication at the moment of time, should be given for shorter duration and stopped immediately. Now, the present era with biological agents and more research going on for the recalcitrant lesions where other modes of modality, second lines, whatever drugs we have discussed, when they are not working, you can always go for biologicals. But biologicals is the last mode of therapy. Why? Because it's very costly. The patient might require around 1.5 lakh for his full therapy to get completed. But the recurrence ratio will always be the same as any other systemic agents we had used before. Among them, the agents we use right now are anti-TNF alpha inhibitors and interleukin 12 and 23 inhibitors can also be used, and secukinumab anti-17A monoclonal antibody inhibitors. Now they've started new therapies which is targeting TS17 pathway. TS17 pathway is like basically it is now targeting the CD4 cells, so that there will be no cytokines released or there will be no interleukins released, which will help in proliferation of the skin. Thank you.